Hello again, I'm Don Scott, and welcome to GBMC Facebook Live. And today we welcome Dr. Jamie Johnston, an orthopedist from GBMC.
That's right. Thank you.
And we're talking about fractures and osteoporosis. And I have to admit, when we were planning this conversation and things without you with us, I thought they were going to be two separate topics. They were going to talk about fractures for a little while, then we talk about osteoporosis. But you're saying that they're really related.
Right. In the United States, there are over 2 million low-energy fractures. We call them fragility fractures. These are fractures that occur in people usually over the age of 50, oftentimes women. They're low-energy fractures, so a trip and fall on your wrist or injure from the fall. Those fractures increase your risk of having another fracture, which is sort of the message we like to get out today, which is if you've had a fragility fracture, you're at an increased risk for having another fracture in the future, especially the ones we worried about are hip fractures. So in the U.S., there are more than 2 million these fragility fractures each year. Half of women and 25% of all men will have a fragility fracture. The U.S. spends over $20 billion a year on fragility fractures. What our goal is if people is to get the message out there that if you've had a fracture of your wrist or of your proximal humerus or a pelvis fracture, that you get checked out by your primary care physician or an endocrinologist for osteoporosis, because oftentimes, like you said, it's that underlying osteoporosis that's thinned and weakened your bones that puts you at risk, and now you're 2 to 3 times more likely than the average person to have another fracture. So our goal with these programs at GBMC is to try and prevent people from having hip fractures. And the way we do it is if you're diagnosed with a fracture, we want you to get checked out for osteoporosis so that osteoporosis can be treated and you can prevent a hip fracture.
But that's of a certain age. If I broke my wrist when I was 30, I'm not more prone to have another broken bone, am I?
No, we focus primarily on older patients. So the majority of this, what we call secondary prevention, which is someone's already been diagnosed with something which is a fracture, and we go to try and prevent the next fracture, that's secondary prevention. We're looking for patients over the age of 50.
Okay. So. I don't want to frighten anybody, but in normal conversation, you'll hear of an older person having a fall.
Right.
And they say, well, did they break anything? And you say, well, they broke their hip, and everybody goes, ooh.
Right.
Why is that? Why is there a feeling that a hip fracture leads to?
Right. So there's some fairly daunting numbers for hip fractures. So nationally, about 25% of people who have a hip fracture will pass away within the next year. It's very difficult to recover from a hip fracture. 50% of the people never regain the same level of function. So if you were walking normally before, you'll likely need a cane, even in the best outcome. If you were requiring a cane before, you might need a walker. But it makes it very difficult to get back. A lot of this program came from a woman I met named Ruth, and I treated her for many years. And she had had a hip fracture. She was a very independent 80-year-old woman and had a hip fracture and was treated at the hospital, and she did fairly well. Well, a year and a half later, she came back and had the other fracture. The other hip had fractured. And same thing. She had tripped and fallen and broken her hip. And when we look back, we realized that she never really had been treated for her osteoporosis. And we felt we had failed her a bit. So we look back on the patients that we treated and we tried to determine what can we do to prevent that next fracture. In her case, a DEXA scan, which is a bone mineral density scan, would show some a low bone mineral density. And in her case, there's a lot of things we could do. So what you're going to do if you have a hip fracture, if you have a low energy fragility fracture, is you need to get a DEXA scan. You need to determine what your bone mineral density is. You need to check your vitamin D and your calcium, make sure you're getting enough of that. We consider the vitamin D and the calcium to sort of be the fuel for healing fractures. They're going to take a history. So if your parents, if your mother or father had a hip fracture, your chances of having a hip fracture are much higher. They'll ask things like, have you had height loss? So oftentimes you'll see these women who are sort of slowly leaning forward. That's because
I watch my father do
right,
that.
Yeah, and that's because they have small compression fractures in their spine, and as each of those compression fractures occurs, people lean farther forward. So one of the questions they'll ask is about height loss. They're going to make sure that you're not drinking heavily or smoking, because those are all make it high risk for osteoporosis. And then they're going to ask about some medications. There's various options for treating osteoporosis. The last and probably one of the most important things is fall prevention. So there's a great saying that a hip fracture is the final result of a decades-long journey of decreasing bone mass and increasing falls risk. So if you don't fall, you don't fracture.
Okay.
So after you have a fracture, in addition to being checked out for osteoporosis with all these lab tests and DEXAs, which sounds like a lot, but actually is quite easy. People can do it in a day or two. You need to get checked out for a falls risk. So as people age, their vision's not as good. They often will have neuropathy in their feet, which can make it more difficult to feel things at night.
Okay.
So it's simple interventions like getting rid of throw rugs in your house, looking for cords, making sure you have a good well-lit area when you're getting up in the middle of the night to use the restroom. All these things can help. In addition, weight-bearing exercise, and they have some more sophisticated tests that the therapist can do. But falls prevention is just as important as the rest of this to preventing the next fracture.
Two things, my personal experience there. When my father was in his 90s, he would get up out of his recliner, and balance was a big problem.
Huge.
So that increased his fall risk.
Absolutely. Since some people, you have to be very honest with them that they'd be safer using a walker. Making sure that they have handrails in their bathrooms, making sure that, some people need to move from a 2-story house to a single story. So these are the kind of things, if you want to prevent hip fractures, and that's really what this is all about, because people have poor outcomes with hip fractures in general. You need to focus on treating the osteoporosis and the falls prevention. So to get back to Ruth, she ended up breaking the other hip. She recovered from it, did very well, but she went from a person who was fairly active, completely independent, to not being as active. She needed a walker to get around, and it was a real wake-up call for us, saying that we need to do more. So in early 2000s, they declared to be the decade of the bone and joint. And the American Academy of Orthopedic Surgeons and the American Orthopedic Association talked about the importance of this secondary prevention. So they've come up with all sorts of programs that are available that help guide orthopedic surgeons and primary care doctors and endocrinologists to prevent the next fracture. So we had started a program like that.
How do I find out about those programs? Is there a website?
So at American Orthopedic Association, Own the Bone program is that's one website. Also at American Academy of Orthopedic Surgeons has information about osteoporosis. And then something called the NBHA, or the National Bone Health Alliance. They have a lot of resources for people about osteoporosis. But RAND Corporation did a study looking at secondary prevention. So nationally, how well we do as a group nationally at preventing fractures. So only around 17% of people who had fractures were treated for osteoporosis, evaluated and treated for osteoporosis. So nationally, we're not doing that great of a job. And I just want, as much as possible, to get the message out that if you've had a fracture, you're over the age of 50, and it's a low energy fracture or a fragility fracture, you should be checked out for osteoporosis so that you don't get a hip fracture in 10 or 15 years.
Gotcha. The other thing I was going to bring up was I'm 67 years old, and about 5 years ago we redid our master bathroom. And my wife said, "How about grab bars?" I said, "Grab bars, you know, we'll get those when we're older." But we had them put in because it was easier to do it then or whatever. And I have to admit, secretly, I've used those a couple of times. And so, I'm glad to hear that's prevention.
Absolutely, it's prevention. You should see the looks I get in clinic when I say maybe you should consider using a cane. It's so it's worthwhile, and It's difficult to accept that you may have difficulty with balance or vision, but using a cane or a walker can be really important.
Okay, it's difficult for me to imagine what osteoporosis is. I mean, I hear it all the time.
Right.
I see Blythe Danner talking about how some
Yeah.
wonder drug does it. So what is osteoporosis?
So osteoporosis is a loss of bone mass or a thinning of the bones, and it's probably best to see. These are great models here. Can you zoom in on this for me? So I'm going to move over here. So I'm not sure if you can see it. This is from a bone biopsy, and then the original biopsy was about the size of a pencil eraser, and then they did a CT scan and made a 3D model of it. And if you can see, this is one cortex here, and this is another cortex here. In between, you can see my finger behind that. You can see how the trabeculae, or the support structure, is thinned.
Is lacy.
Yeah, very lacy. So it's osteoporosis. There's lots of pores, or lots of holes in the bone, and the trabeculae are thin.
So that was once solid?
Yeah. So, and then this is another. There's a certain medication that's available. I won't say the name, but there's a medication available where after treatment you can have significant increase in the thickness of the bone and the bone quality and the bone structure. So I think people really like to see this. They understand the difference between the porosity over here and then compared to this side where you can't see anything through and the bone's a lot thicker. But that's really all it is. It's a bone that has less density and has worse structure. And it happens a lot of times in postmenopausal women. It can happen in other instances, like people on steroids. People with GI issues can have difficulty with osteoporosis. But it's really just the thinning and the weakening of the bone structure.
And there's no symptom that I'm sitting home on my couch and suddenly go, I think I've got osteoporosis, right?
Right. It's just like it's a silent disease. In fact, a lot of those fractures, like the spine fractures, there's more than 500,000 of these spine compression fractures here. A lot of those people don't even feel. They just start noticing themselves sort of leaning forward.
Okay.
But yeah, so it is kind of like a silent disease. When you have, when you're looking for people who are at risk for heart disease or strokes, they'll check your blood pressure. We don't have a great test other than the DEXA scan. With a DEXA scan, you lay down, it's very easy. It's about 15 minutes, and they can measure how dense your bone is. That's one very good test.
Okay. No pain involved?
No pain involved. It's just a matter, you have to lay on a flat table for about 15 minutes. Okay. But that's probably the best way, in addition to your history, to determine what your risk factors are. But in the end, the best determination of whether or not you're going to have another fracture is whether you've had a fracture in the first place. So you're 2 to 3 times more likely to have another fracture. And about 20% of all hip fractures, about 100% of hip fractures come from just 20% of the population. So if we can really focus our energy on people who have had fractures, making sure that they get checked out for osteoporosis, get fall prevention, we can decrease hip fractures.
Okay.
There's a program at Kaiser in Southern California called the Healthy Bones Program, an orthopedic surgeon named Rick Dell. And they showed that over about a 5-year period in that entire Southern California Kaiser area, population, which is huge, they could decrease hip fractures by 40%. So year after year after year, you have 100 hip fractures, and then all of a sudden they had 60. So at GBMC, we treat about 158 hip fractures, most recently about 158 hip fractures last year. So imagine if we could wipe away 30 or 40 of those hip fractures, and those people would not have to recover from it, and it would be great. But we really have to focus on prevention.
Gotcha. I want to engage some of our audience that's paying attention to what we're talking about. Yep. So Kelly's a 57-year-old female. My names are mixed up here, but with a history of osteoporosis and multiple compression fractures. She's on Forteo? Forteo now. What's your opinion of the drug, and will it lessen her chances for more?
So Forteo, actually, this is all from Forteo. Forteo is a medication called teriparatide, and it's a parathyroid hormone analog. It's normally parathyroid is a hormone in your body that tightly determines how much calcium is in your blood. Usually if you have a lot of parathyroid hormone, you will actually lose bone mass. But for whatever reason, the drug company realized that if you give a very small dose of it every day, small dose of this, it's an analog of parathyroid hormone, you actually increase bone. So it's
counterintuitive.
It is counterintuitive. So the thing that's difficult about it is it requires a daily injection, and it's extremely expensive. So I'll just talk for a little bit about the medications.
Okay.
So so first of all, for osteoporosis, you want to make sure you get enough calcium and vitamin D. But then there are medications called bisphosphonates. So have you ever heard of Fosamax?
Sure.
Yeah. So everyone's heard of Fosamax or alendronate. That was a medication that used to be on patent. Now it's available as a generic. It costs about $70 per year. So that medication is something you take once a week. You need to be able to sit up for 30 minutes because it can irritate your stomach lining.
So it's oral?
It's oral.
Okay.
Take it once a week by mouth, and it can significantly decrease your fracture risk. The way that those medications work, these bisphosphonates, is imagine a bathtub, and on one side you're filling up the bathtub, and the other side you have the drain. So there's cells in your body called osteoblasts that build bone, and there's cells called osteoclasts that take away the bone. And you're constantly building, taking away. The remodeling is constantly happening. The bisphosphonates, or Fosamax, is one of them. There's 5 or 6 of them. They kill osteoclasts, and they make them stop functioning. So imagine all the water that's coming out, they stop that. So what happens in older people with osteoporosis is they're no longer building as much bone, so you then stop the leakage out with these osteoclasts. The problem is there are some issues with bone turnover. So you're not getting that normal bone turnover with these medications. So those medications, the Fosamax used to be extremely popular. What's happened a lot of news stories came out. There was some famous news stories about people having trouble with their jaw. It was called avascular necrosis of the jaw, and these things called atypical femur fractures. So if you put someone on Fosamax for 5 years, and you basically shut down the bone turnover, they can have issues with atypical femur fractures in their thighs. What they realize is if you do it for 5 years and then you take a drug holiday for 2 years, those tend not to happen. And if you maintain the regular dose instead of using very high dose medication, you don't have the risk of the avascular necrosis of the jaw. So those medications are safe and effective. They can decrease fracture risk, and they're inexpensive, which is very nice. There's other medications that you can give so for instance, if you have a patient who can't tolerate taking a pill every week or sitting, you can do an infusion. You can do a once-yearly infusion of something called zoledronic acid. There's something called Prolia, which is what
Blythe Danner advertises on TV.
Yeah. So
I see it all the time.
So that one is a once every 6-month subcutaneous injection. So just like your flu shot, but twice a year.
So just a shot, not an intravenous thing.
Nope. It's just so that's a very easy shot that you can take. Forteo is, of all those medications, Forteo is the only one that instead of acting on the drain, instead of preventing the bone loss, it actually operates on the faucet. So this medication, it's a little bit, but it actually builds bone. So those osteoblasts that are building bone are activated by Forteo. So to get back to her question, what do I think about it? It's phenomenal. It's amazing science. It's like one of the coolest things that's happening today is understanding how bone works. There are some issues with it. It's expensive, and when they were testing it initially, many years ago, it's been in use for 12 years, very safe. But when they were initially testing it, some of the rats that they gave it to got osteosarcoma. So osteosarcoma is a bone tumor. So there's a large black box warning on Forteo that says you can't take it for more than 18 months to 2 years, because they're concerned that if you take it too long, you might develop these tumors. So, and it gets to this question is, if you're a primary care doctor, if you're a patient, and you're told, oh, well, this medication may cause an atypical femur fracture. This one might cause my jaw to wear out. This one might cause osteosarcoma. I'm done with this. I'm not even going to deal with it. But in reality, the medications are safe and effective, and inexpensive in some cases, and they do work. And it's something where so many people come into me and they have a hip fracture or they've had a proximal humerus fracture, and I say, boy, why didn't you take that medication, or why weren't you ever evaluated? And they say, oh, I was worried. I didn't want to take this medication. But so part of our message is it's important to be checked out, and there are medications and therapies that are available that can help you prevent that next fracture.
You said Forteo was expensive.
Very expensive, yeah.
How expensive were we talking about?
Thousands of dollars.
And is it covered by insurance for the most part?
Yeah, in general, so they have special programs. The pharmaceutical companies have there's something called Forteo Connect that will help patients get it paid for. So it's one of those things where if it's the right medication for you, they can usually make it happen. But there's a lot of other options too. So the broad spectrum of different medications. And like we said, some of the simplest things like physical therapy, fall prevention are probably just as effective. So.
Okay, you also mentioned hip replacements. We talked briefly about that.
Right.
I would think as a layman that if I've broken my hip and you give me a hip replacement, and it takes whatever that means, I'm cured, and there's no problem. First of all, how do you replace a hip?
Yeah, so I mean, so my training is in hip and knee replacements. I did a fellowship at Mayo Clinic in adult reconstruction and learning how to do this. This is what I focus on. It's just because I see so many people with hip problems that I got so interested in osteoporosis and hip fractures. So this is, well, the way we replace a hip is, I'm not sure if you can see this here, but this is a model. So you have, if you were to break the femoral neck here, this is where the ball would normally be. If you were to break that, you put a stem in to the femoral to the femur, and then there's an acetabular component up here, which would go up into the acetabulum, and then the hip would be repaired. So you can move the hip. And,
so it's a ball joint.
Yeah, it's a ball and socket joint. It's people who have a femoral neck fracture and get a hip replacement actually do fairly well. So. There are other kind of fractures. There's some fractures that we treat with something called an cephalomedullary nail, and that can be harder to heal. So you actually have to get the bone to heal. So,
as a woodworker, that would have scared me.
Yeah, we've got all sorts.
Looks like a drill bit.
Don these before, but we have a lot of things available. We want to prevent hip fractures, but when they do occur, we want to do our best job we can treating them. So at GBMC, we have a lot of resources available for hip fracture patients. We have Dr. Riley, who's head of geriatrics, and they have a huge group, 15 geriatricians at GBMC who really help to ensure that patients get the best care if they do have a hip fracture. We want to prevent delirium. People can get very confused after a hip fracture. We have a great therapy group, and then afterwards they can really help with a great rehab group. So,
why do you get delirium after a hip fracture?
Well, it's complicated.
It's
yeah. People. So, delirium is people always talk about dementia, where you have loss of memory and you can't function. Delirium is they call it acute encephalopathy, where the brain sort of stops functioning normally. We're not sure exactly why it is, but it can be a new environment. So someone is functioning pretty well at home. They come in with a hip fracture. They're not used to the environment. They're often on pain medications, or they're in pain, which can make it difficult. Okay. They have electrolyte abnormalities, so their potassium or their sodium might be off. They might have urinary tract issues. And then there's blood loss associated with the fracture and with the surgery, and then because of that, we often have to give them fluids, and so all those things can lead to delirium. So we want to do everything we can to prevent that.
And just to make sure that I understood correctly, so we now replace somebody's hip.
Yeah.
That does not stop them from the threat of breaking further bones, or needing to be checked for osteoporosis.
Well, that was the problem. I mean, it's such a big deal. If you imagine your mother breaks a hip, she goes to the hospital, you fix the hip, they go to rehab, it takes weeks or months for them to get better, and then everyone sort of wipes their brow and says, wow, I'm glad that was over, but it really isn't. The next thing is, let's prevent them from breaking another bone. Let's prevent them from breaking their spine, from getting a compression fracture. So what we often forget is that secondary prevention. So at GBMC, we have a wonderful relationship with the geriatric group there in Bay West, and Dr. Ruth Horowitz is in charge there. And they are phenomenal. They've been doing this for years at treating patients with osteoporosis. So, that's a great resource to have there. So oftentimes people, one of the questions that I saw was why, if I have a hip fracture, why is the orthopedic surgeon asking me to see an endocrinologist? Don't they deal with your thyroid and diabetes? Well, as it is, they actually deal with osteoporosis as well. So they can help manage the treatment of osteoporosis so that we prevent that next fracture.
Okay. I saw our producer standing by here. Am I not getting a message? We communicate by phone here. Go ahead, Mindy. Mindy?
We do have a question. I'm having a little technical difficulties on my end. Carol asks, do cortisone shots affect bone density?
No, not in general. I wouldn't. I think the steroids that we're concerned about are things like prednisone that you take by mouth, and they can really affect the way you make bone in your body and the quality of the bone. So I wouldn't worry about a steroid shot in your knee, though. That's pretty low dose. It's once every few months, but.
I'm trying to get my technology back
Oh,
together.
that's all right.
But what happened when we brought up that you want to be sure we do before we wrap up here?
Yeah. What would I like to? So
Yeah,
my message.
What haven't we done that you want to do?
So I have a key message, and that's that if you've had a prior fracture, you're at higher risk for a future fracture. And there's a lot of simple interventions like fall prevention, exercise, making sure you get enough calcium and vitamin D, and smoking cessation, avoiding alcohol. Those things, along with medications, can really help decrease your risk of having another fracture. And we have a lot of resources at GBMC with the geriatric group and the endocrinology group, and it's really exciting to work with them. And it's unfortunate when someone breaks a hip because it can be very difficult to recover from, but it's also an opportunity to prevent the next fracture. So if you're over 50 and you have a fall and you fracture, you should be checked out by your primary care doctor or endocrinology to make sure that you are not at risk for future fractures. That's really the main message.
Which brings up another question that Mindy had, and that was somebody's in their late 30s.
Yeah.
Is it important for them to take something to prevent osteoporosis in the future? Do you recommend supplements?
Yeah.
Do I prepare in my 30s for what's going to happen
so
in my 60s?
So if you're in your 30s, the main goal is to get to your, so when you're younger, you're talking about peak bone mass. So you want to make sure you're exercising regularly, doing weight-bearing exercise. You want to avoid smoking. You want to avoid heavy alcohol. And other than that, there's not really any medication. They don't recommend getting your DEXAs until you're older. So your risk really goes up as a woman in the postmenopausal years. But as that estrogen comes out of your system and the bone, you can have very quick, rapid osteoporosis onset. But younger people, it's about avoiding smoking, getting enough sunlight, avoiding heavy alcohol.
Does osteoporosis happen in old men then who aren't postmenopausal?
It can, yeah. So there's absolutely. There's this great story I remember of a gentleman who was a biker. He was avid. He would bike hundreds of miles, in the weekend. Just incredible biker, and on a road bike, not a motorcycle.
Sure.
So he's
I
actually exercising.
I understood that.
Yeah.
I understood that.
And he fell and broke his hip. And he went in and had the hip fracture treated and did well. He was back on his bike again. And then 2 years later, broke the other hip. And he was telling this story.
From a fall?
From another fall.
Okay.
And they said, well, why on earth am I back in the ER again? What could I have done? And again, they checked the DEXA. He had a very low bone mineral density. And he was at very high risk for fracture. So just because you're an athlete and you're male doesn't mean you don't have osteoporosis. So it's much more common in women than men. Okay. But if you're over 50 and you fracture, even if you're a man, you should get checked out. Certainly talk about it with your primary care doctor, who are sort of the drivers of this movement. So,
a close personal friend has had a hip replacement and recently, and his question would be, how long does it take to recover?
So my mentors told me, and I tell everybody this, it takes a full year to recover after a hip replacement. Most of the recovery is in the first 8 weeks. You have about 80% recovery. That's for the average person who walked into the operating room with an arthritic hip. It's a little bit different for someone with a hip fracture because oftentimes there's medical issues going on. There's often significantly more blood loss because they have the fracture, and then you bleed from the fracture, and then you also bleed from the surgery. So, for the average person with hip arthritis, you can be up and moving pretty quickly. The way these implants work, this is a slightly different topic, but for a hip replacement, we have this porous coating, so it looks a little bit like sandpaper. I'm not sure if you can feel that.
Yeah.
But the way that the hip replacements work is you put it into the femoral canal, and then the bone actually has to grow onto it.
So it gives it something to grab onto.
Yeah. So
like primer for paint.
Like primer, but actually it's active. Like we were talking about how the medication increases those osteoblasts. So when you get, after 6 to 8 weeks, this thing will be part of you. It will be solidly fixed. The bone will have grown into the implant. So we tell people, we're always trying to get people up and moving quickly after hip replacement, but in reality, for the first 2 weeks, you do have to be careful because the bone has not yet grown into the implant. It's just a scratch fit or an interference fit.
Okay.
So, yeah, I'd tell your friend he should be up doing most things within 6 to 8 weeks. If you do have a hip replacement, I wouldn't recommend doing high-impact activities. So if you're going to play tennis, you play doubles tennis. Swimming and biking are great, but I wouldn't do the high-impact
You're
stuff.
not healed like that.
Yeah, not healed like that.
Okay. This has been fascinating. Thank you very much.
You're welcome.
Again, it's
Thank
Dr. Jamie Johnston, an orthopedist at GBMC.
Yep.
And we have something new to do today, and that's GBMC is one of the sponsors of the Baltimore Speaker Series, and we're going to give someone a ticket to see David Cameron. He's not a doctor that I know of.
Yep.
The former Prime Minister of England, and it's going to be on October the
All right,
3rd.
great.
And you're going to be the lucky person, well, you're going to choose the lucky person.
All right. It's Maria P.
Maria P.
All right, she'll be very excited.
All right, very
That's
good.
great. Thank you.
And thank you again for
Yeah,
this time.
thanks for having
I
me.
was fascinated all the way through, and I hope to keep my bones healthy. What is it, own your bones?
Own your bones. Yeah,
Okay.
we want you to prevent the next fracture.
And I'm thinking about having grab bars installed. Up here, we're up in the air
right.
a lot. Thank you for taking part, and we'll be back in a month or so. So for GBMC, Facebook Live, I'm Don Scott. Have a great day.